chest tube day can go from calm to chaos in seconds. Bubbling that won't stop. Tidaling that suddenly disappears. Output flatlines, then surges bright red. In this video, I'll show you how to read the system like a pro, spot trouble early, and act with confidence. So when things get messy, you stay steady. Chest tubes drain air, blood, or fluid from the pleural space to restore negative pressure and let the lung re-expand. They're common after thoracic surgery, pneumothorax, or pleural effusion. Complications aren't rare, and they escalate quickly. Your edge comes from pattern recognition. Is that bubbling normal? Why did tidaling stop? Is the system actually below the chest? Did we just create a dependent loop? In the next few minutes, you'll get a bedside framework that works on any unit. Here's what you inherit at the bedside: a chest tube anchored at the insertion site, tubing coiled and secured, and a drainage unit with 3 core zones: collection, water seal, suction control. Systems come in 3 flavors: wet suction, classic water column, dry suction, regulator dial, or water seal only when gravity drainage is appropriate.
As the nurse, your immediate responsibilities: keep the system upright and below chest level. Ensure tubing is patent, no kinks, no dependent loops, and all connections are secure. Assess respiratory status: O2 sat, pain, breath sounds. Watch the water seal for tidaling with breathing and bubbling patterns. Trend amount, color, consistency of drainage, especially the first 24 hours.
Think of the lung as a balloon in a sealed box. When the box gets a hole, pressure equalizes and the balloon deflates. The chest tube is your one-way straw. Air or fluid exits, but can't re-enter. The water seal chamber is the valve. Suction, wet or dry, just helps maintain the outward pressure gradient so the lung re-expands faster.
What you see in the water seal matters. Tidaling that rise and fall tells you the tube is patent and tracking pleural pressure. Intermittent bubbling can be normal as residual air leaves the pleural space. Continuous bubbling usually means an air leak in the lung or the system. Your job is to correlate. What are the breath sounds? What's the SpO2? What does the patient look like?
When things go sideways, it usually follows one of a few risk pathways: blocked drainage, retained air fluid, recurrent collapse, tube dislodgement, open pneumothorax risk, persistent air leak, ongoing collapse or spreading subcutaneous emphysema, excessive bright red output, hemorrhage, contamination, infection, or empyema. How fast can this escalate? Dislodgement or sudden blockage can progress to tension physiology in minutes. Air leaks and subcutaneous emphysema may evolve over hours. Infection usually takes days, but starts with breaks in a sepsis. The subtle traps. No tidaling might mean the lung is fully expanded, or the tube is blocked. Intermittent bubbling can be fine. Continuous bubbling is a red flag. And crepitus at the site, don't shrug that off.
Start with placement and safety. Verify the unit is upright and below chest level. Straighten tubing, remove dependent loops, retape loose connections. Assess vitals, work of breathing, breath sounds, SpO2. Inspect the dressing, keep it occlusive, clean, and dry. Read the water seal, tidaling present, bubbling pattern. Mark and trend drainage. Early on, hourly marks help you catch patterns.
Do not clamp the tube just to check. That can trap air and precipitate tension, unless you're performing a brief, ordered maneuver for troubleshooting or changing the system. Do not routinely strip or milk the tubing. This can generate dangerous negative pressures without improving outcomes. Don't lift the system above chest level, and don't change the unit unless it's contaminated or full.
Escalate now if sudden respiratory distress or new absent breath sounds. Bright red drainage, 200 ms/hour for several hours. New or spreading subcutaneous emphysema. Loss of tidaling with clinical deterioration. Tube dislodgement. Apply an occlusive dressing to the site and call for help.
Use this flow when alarms go off in your head. A. Continuous bubbling. Verify all connections. Tighten and tape. Brief, ordered step clamp along the tubing to localize leak. Device, patient. If leak is at the insertion site or patient, escalate. Consider suction per order. B. No tidaling plus patient looks worse. Check for kinks, loops. Straighten. Confirm water seal level and unit position. If still absent and patient's deteriorating, call for help. C. Output stops unexpectedly. First 24H. Assume blockage until proven otherwise. Inspect tubing end to end. Consider ordered flush protocol or device change if contaminated. If pneumothorax case with minimal fluid, no drainage may be expected. Correlate with assessment. D. Tube pulled out. Occlusive dressing over the site. Monitor for distress. Notify provider immediately.
Lock this in with tube safe. T. Tubing unobstructed, straight below chest. U. Unit upright and secure. B. Bubbling and tidaling assessed. E. Exit site dressing intact. S. Suction level appropriate. A. Amount and color trended. F. Focus on breath sounds and patient status. E. Escalate early on abnormalities.
Don't get burned tip. If drainage suddenly stops, assume blockage until proven otherwise. And the red flag many miss, subcutaneous emphysema creeping across chest or neck. Treat that like an air leak emergency. Post-op lobectomy, dry suction at 20 cmH2O. First sign, RR creeping up, SpO2 down a couple points, patient more uncomfortable. You check the unit, continuous bubbling in the water seal. You secure a loose connection, bubbling slows to intermittent, patient's breathing eases. You reassess, mark output, and document. 10 minutes, calm restored, because you knew what the pattern meant and how to act. This was Chest Tubes 101 for nurses on the sharp end of care. If you want more cinematic, bedside-ready guides like this, subscribe to SkillTree Nursing. Drop your chest tube questions in the comments and tell me what scenario to tackle next.